Welcome, everyone. I am Brandon Doucet, a dentist that works in the federal prison system. Every day I see the consequences of people lacking access to dental care. I am the founder of the Coalition for Dental Care and author of About Canada Dental Care, a book I wrote with Fernwood Publishing that I recommend all of you check out if you enjoyed tonight's webinar. Before we get started, I would like to first acknowledge that while we are meeting virtually this evening, I would like to begin by acknowledging that I'm presenting from Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq people. As you are all joining us from across the country, I encourage you to consider the traditional territories upon which you live and work. We must also recognize and underscore the significant and unjust health disparities that Indigenous people continue to face today due to systemic racism and ongoing effects of colonialism. Before we begin, I'll just run through a few housekeeping matters. The webinar will be recorded so it can be shared with those who couldn't join us this evening. Please feel free to open the webinar chat and send chat messages to hosts, panelists, and attendees. Let's definitely engage with one another in the chat box. We'd love to know where you're calling from and why this issue is important to you. You can ask questions through the Q&A function at any time during the webinar. We'll try to get through all of them during the Q&A, but we will also follow up over email if we don't have time to address your questions tonight. And lastly, closed captioning is available for this meeting, so please feel free to turn it on. This event will run approximately until 8:15 p.m. Eastern Time. And thank you for sharing your evening with us. As you might have heard, the Canadian Dental Care Plan is being implemented in a stepwise fashion, with seniors making less than $90,000 per year being the first group to become eligible. Between December 2023 and March 2024, seniors 70 and up who fall in the income range will be sent an invitation by mail with instruction of how to apply for the dental plan by phone. In May 2024, the application will go online for those aged 65 to 69, being eligible first, followed by children under 18 and adults with a valid disability tax credit certificate in June of 2024, and the remaining adult population who fall under the income threshold becoming eligible in 2025. While people are currently applying for the dental plan, they're not expected to start receiving benefits until May of this year. While people who have private dental insurance are not eligible for the Canadian Dental Care Plan, those who are covered by one of the meager provincial or federal dental plans will be eligible and will see their patchwork benefits replaced with more comprehensive coverage. The Canadian Dental Care Plan is expected to help around 9 million Canadians access care, but the amount of help will vary based on one's adjusted family net income. Those whose income is less than $70,000 per year will have no co-payments, whereas those whose income is between $70,000 and $80,000 per year will face a 40% co-payment, and those with an income between $80,000 and $90,000 per year will face a 60% co-payment. These co-payments will undoubtedly get in the way of Canadians accessing this much-needed form of primary health care. On top of this, a recent report from the Canadian Centre for Policy Alternatives shows that with the Canadian Dental Care Plan, 4.4 million Canadians will still be left without dental insurance, and many more will be left underinsured and struggling to access care. Considering that Canada's rate of public dental spending ranks second last amongst OECD countries, leaving 1 in 3 Canadians without dental insurance and 1 in 4 avoiding the dentist each year due to financial constraints, the Canadian Dental Care Plan is welcome news for anyone who has put off dental work because of the cost. But much more work is undoubtedly needed. In that context, I would like to welcome our first guest, Dr. Paul Allison. He is a dentist with specialist training in oral and maxillofacial surgery and a dental public health and with research training in epidemiology. He has been Dean of the Faculty of Dentistry at McGill and President of the Association of Canadian Faculties of Dentistry and of the Canadian Academy of Health Scientists, and has been on the governing council of the Canadian Institutes of Health Research. He is currently a member of the Lancet Commission on Global Oral Health, as well as a leader of a national Canadian research team working with Statistics Canada. He is also co-chairing the development of the National Oral Health Research Strategy. So, Dr. Allison, how would you contextualize the Canadian dental care plan thus far in the broader history of dental care in Canada? And what things are you looking out for in the short and to medium term to ensure that the Canadian dental care plan is a success?
Well, thank you very much, Brandon, and thank you everyone for tuning in. It's a real pleasure to be here discussing this really important topic. So, to answer your question, the first part, in terms of the historical context, clearly, if we go back to the beginning of public healthcare in Canada, the ideal, and certainly in my perspective, would have been to include dental care in Medicare. But at the time, back in the 60s, there was a decision to exclude that and pharmacare, which of course is also on the political cards at the moment as well, with the idea that those would be phased in the coming years. And of course, financial constraints and political decisions made that not happen. And so we move on another 60 or so years, and finally we're beginning to see that we need to change things, because in the interim, the provinces have tried to step in a little bit here and there, try to put their finger in the dike or a few holes here and there, and a patchwork of small public programs has been developed. And as you said, Brandon, we have in Canada, until this moment, when the federal government is starting to invest very significant sums of money in dental care, amongst OECD countries, the smallest amount of publicly funded dental care, with only approximately 6% at this stage of money spent on dental care in Canada coming from the public funds. So we've ended up over the last 20 years or so with this patchwork, very confusing to everyone concerned: patients, dentists, decision makers. So it's not helping people very well. And we've also seen increasing inequalities. We've seen that the burden of dental disease is enormous. Dental caries remains the most common non-communicable disease in the world and remains extremely common in Canada. So it's very clear to see that we're not addressing this issue very well. So that's become clearer and clearer to decision makers, and I think the pressure has mounted to such an extent where politicians, we've heard in the last few elections, politicians in provincial elections and federal elections talk about it, and finally a decision has been made to invest in public dental care, which is fantastic news, and it's a very significant step forward. Of course, we can all criticize it. There's things we can. There's all sorts of details that we can readily criticize. But I think it's really important to say that this is going to help, as has been estimated, and you mentioned, Brandon, approximately 9 million people in Canada get access to dental care, which is fantastic news. Of course, there are still limits in the sense that you have to have signed up to pay your federal taxes to get access to this, because this is how they're going to start to work out who gets to be within the financial earnings brackets that Brandon mentioned. So, of course, there'll be plenty of people who are going to be will not be able to get access to this program because they don't, for a range of reasons, sign up for their federal taxes. And then after that, while the program itself is really good in terms of addressing financial barriers, it doesn't address all sorts of other important barriers that many people in Canada still have, sometimes on top of those financial barriers, sometimes separate to those financial barriers. We're going to hear lots about those, I'm sure, from other panelists here today. But if we think about people with disabilities, that's a really important group who have all sorts of difficulties getting to dental offices. And unfortunately, dental professions are at the moment very poor at going out to those groups. And it may be people living in their homes, or it may be people living in long-term care centers of one sort or another. And those are really big and important groups that need access to care. And this program won't address that. There are plenty of other groups, people who live in rural and remote areas, people who are recent immigrants, people who have struggled to understand the program, etc., etc. So there are plenty of examples, and we still have problems with very young children getting access to care as well, even though they may be covered. There's lots of research showing that young kids are not getting good care. So, for instance, dental caries is the most common cause for young children in Canada to have a general anesthetic. Just to state how common the disease is, and also in my mind, that's a somewhat disappointing statement of access to care, the fact that they have to be put to sleep to receive their care. So when we ask the question about what are we looking forward to, it's true that as well as this major program, the federal government has created what it calls the Oral Health Access Fund, which is a significant amount of money, which they say, and again, as with many details that need to be resolved around this program, it's not entirely clear exactly how it's going to be used, but the idea is to help those groups that I've just brought up. So people with disabilities, people who live in rural and remote areas, et cetera, So to try to help overcome the barriers that are not just the financial barriers. We'll have to see how that rolls out. We'll have to see whether there's enough investment to cover those issues, because in my mind, we really have to invest quite a lot in infrastructure to enable dental care to be delivered for those groups. People with disabilities often need a whole range of adaptations to the dental office, and the dentist needs those adaptations to serve people with disabilities, and that costs money. We need to take the dental services and the dental care and the health professionals to these people as well, as opposed to have the classic model where we expect people to come to a dental office. That's fine for many of us, but there are a significant number of people for whom we, the professionals, need to be going to them, and we need to set up the mobile facilities. We need to set up facilities in long-term care centers. We need to set up facilities in community health settings integrated with medical and social services, so that when the family physician or the pediatrician or the geriatrician or whomever is seeing a patient for a range of health and social issues, they can say, it'd be a great idea if you go and see the dentist or the dental hygienist just down the corridor. There they are. And by the way, they're part of this federal program, so it's going to be free dental care as well. And of course, in the long run, I strongly believe that this is a great step forward, but we need to be making dental care part of the universal health care system that we have in Canada for most other elements of our healthcare. Thank you very much, Brandon.
Thank you, Paul, for those insightful comments. I really appreciated how you highlighted how having dental insurance does not necessarily mean you have access to a dental provider willing to do the work, and how we need to look at those alternative dental delivery models outside of the private practice model to make sure people not only have access to insurance, but actually to dental care. I think one point I'd love to add is just basically looking at the success of the Canadian Dental Care Plan. One thing I'm looking forward to seeing is exactly how the fees of the Canadian Dental Care Plan compare to private plans. If we start seeing discrepancies in fees between public and private plans, we'll start to see discrimination against those people. And the greater the disparity is, the more discrimination we'll see. Um, yeah, and on that note, I'd love to introduce our next guest, Joan Rush. She is the Advocacy Committee Chair of the Canadian Society for Disability and Oral Health. Joan is the former General Counsel and Vice President Law for Canadian Life and Health Insurer, and she subsequently advised health authorities and dental organizations. Joan completed her Master's of Law degree at UBC, focusing on health law and ethics, and is a former adjunct professor in the faculties of law and dentistry at UBC. She was the director and governance chair of Community Living BC and was formerly vice president of the BC Developmental Disabilities Association and is currently a member of the Canadian Institutes of Health Research Network and the Canadian Oral Health Research. In October 2023, Joan was made an honorary fellow of the American College of Dentists in recognition of her advocacy. And Joan, I'd like to ask you, what unique struggles do people with disabilities face in accessing dental care? And what are your thoughts on the Canadian Dental Care Plan thus far in addressing those concerns?
Thank you very much for having me. I have to thank Dr. Allison for already mentioning quite a few of the challenges. I would also like to mention that I'm coming speaking to you from the traditional lands of the Musqueam, Tsleil-Waututh, and Squamish nations, all part of the Salish nations here in British Columbia. At this moment in time, this beautiful territory that I'm fortunate to live and work on is covered in snow, which took down some of the internet. And so I'm appearing to you from my cell phone. So I hope that doesn't affect anything too much. If there are problems, you don't understand what I've said or can't hear me well, please feel free to send emails back that I can subsequently answer. But I would like to say that Dr. Allison did touch on many of these things. The fact is that he certainly has been a leader in this, recognizing the challenges faced by Canadians with disabilities, but some specific points have been made over the years from members within medical and dental communities to comment on how oral health is vital to overall health. I think we've agreed, and we've been hearing it quite a bit for the last couple of years, how oral health constitutes health, that we cannot argue that it is anything else, except that if you are a person with disabilities, it is perhaps a social service and therefore somewhat discretionary. So in the provinces, most of them, some have changed in the last few years, but most of them, they offer the minimal coverage for dental that Paul mentioned. It's disparate and varies across the country. For the most part, it's dreadful. But it's offered usually through the social services ministries, which makes it, of course, extraordinarily difficult to coordinate with the necessary health infrastructure that is often needed for people with complex medical or neurological or neurodiverse or other comorbidities. At any rate, the first thing that I hope is that the advent of the new federal health program launches a positive discussion with the provinces. Not all of them are happy to see any federal sort of first off the base work in an area that covers healthcare, because they believe that health is a matter which is constitutionally left to the provinces. In fact, hospitals under the Constitution fall to the provinces. But as you all know, as doctors and anybody else who's licensed professional, if you're a dentist or a doctor, you are aware that you are licensed provincially, and healthcare delivery is a provincial matter. So we're looking at a need for a plan to have a smooth, seamless delivery, and yet the existence of coverage will not necessarily meet that delivery requirement. So the provinces will have to agree that they're willing to coordinate. We don't know yet whether hospital clinics will accept the new dental plan. We hope they do. Only one of the dental schools, to my knowledge, has agreed that they will, at their own dental clinic, accept the new dental plan. I inquired with my local dental school at UBC, and they said they're waiting for the ACFD. So perhaps that's something that Paul can work on. They say they want advice to know where they should take that question, how they should, whether they should in their systems deliver care and accept the program. But for people who could go into community clinics, I think a second major challenge facing them is that there is a serious lack of trained professionals in this country. We are aware of the need, but it is a challenging, difficult I guess, educational stream. It's maybe not as difficult as it is perceived to be, but one way or another, it is clear that it is not taught. There's no mandatory training at any of our dental schools in Canada. There's some dental training in special care, but primarily focused on geriatric patients. And so persons who transition from pediatric hospitals, where many children who are identified as having disabilities can receive care and do receive, I guess, the best trained care they have. When they are transitioned to the adult system, which happens much sooner than it should, but of course the pediatric hospitals, as Paul alluded to, are quite overwhelmed too, with the number of children that need care. And so in my experience and that of literally dozens of people for whom I've advocated trying to access care for their disabled family member, when you hit the adult system, you fall off a cliff. Now, it is, and the care, even in hospitals, is not always very expert. The expert care that is granted privileges in hospitals is usually to the oral and maxillofacial surgeons, and their expertise is called on to extract teeth. And so the Dental Directors of Canada acknowledged that persons who live with developmental disabilities are far more likely to have lost teeth and have the greatest, present as not completely edentulous, but having lost numbers of teeth more than the general public. Something also we should know, this is not a small group. As of the last health measures survey, fully 27% of the country now identifies as having a disability. Probably that number will grow as we all age. But a smaller proportion have developmental disabilities, which are perhaps the more complex to have people accept typical dental care surroundings. But they do. I work with experts in the Canadian Society for Disability and Oral Health who have community clinics where they see persons from a young age, but they see persons right through into adulthood, and they've learned methods and systems to be able to treat them. But they are few and far between. As Paul mentioned, and it's very true, not only do very few hospitals in Canada have accessible clinics for persons with disabilities, sometimes they have only one, maybe two in a province. I think Ontario is a bit more fortunate than the rest of us, but in BC, people are frequently flown to Vancouver General Hospital if their needs are complex. It's an expensive way, and of course, it has usually poor outcome because of the drag in time. People with disabilities wait long periods of time to access care, and the consequences are that their level of decay is worse by the time they are seen. And so you all work in the system where you know that probably people who are providing the same kinds of medical services that you do in the province next to you or 3 provinces away from you, their medical healthcare system covers slightly different things. It's interpreted slightly differently. We have a very poor organization and coordination of our interpretation provincially of how to deliver care. And so it would be a very good thing if we could try, at least since this is going to be a new thing, to figure out how it should work for delivery of dental care where the province is involved in ensuring delivery. As Paul said, we should and do need, I'm just watching my time here, we do need access to clinics that cost money. I worked on a project that went to government, and many suppliers were willing to provide low cost, delivery because of the nature of this being for the public good. And, I had expertise from especially Ontario and Quebec clinicians who work in clinical settings on how to develop one. We wrote a very good presentation. The dean at the time of UBC helped put it all together, and it was refused by government. It's unfortunate, but it has not been seen as a priority at all to ensure that people, and remember, this is not necessarily devoted just to people with intellectual disability or other types of profound disability identified as children, where perhaps there's an assumption, there is an assumption that there are special places they can go. Just to be clear, there are not. But nevertheless, a clinic like that could also offer, which we pointed out, certainly from the faculty, an opportunity for clinical research. We have very little clinical research involving especially dental care needs and treatment options for people with disabilities in Canada. They've just not been part of the bigger scene. But even for other issues, I've talked with dentists whose particular expertise is oral cancers, and they are researchers in it, and there's not enough money for clinical research in Canada. So I'm probably going to repeat this 3 times to you, but as doctors, what I think you should be trying to bring back to your own delivery systems, to your provinces, to your hospitals, to your associations and colleges, is that we need to have better integration across the country of health and dental, that it's mandatory, but that we even need to have better integration with one another. And I'll come back to some other issues later. I'll let my talk go there.
Thank you, Joan, for those insightful comments. It's very interesting hearing your perspective, especially how it takes added time in many cases to treat people with developmental disabilities, which disadvantages these people in the traditional fee-for-service private practice model, and needing those alternative dental delivery models where we look at providers maybe having a salary can help, give the people an equal opportunity at having the adequate chair time, resources, access to sedation needed to be able to treat these people adequately, not just with extractions when they get to the oral surgeon, but with comprehensive dental care. I would like to now introduce our final panelist, Dr. Hasan Sheikh. He is an emergency and addiction medicine physician in Toronto and an assistant professor at the University of Toronto Department of Family and Community Medicine. He is a board member of Canadian Doctors for Medicare and helped co-author the Canadian Doctors for Medicare's position statement on the need for public dental care in Canada. So Dr. Sheikh, can you talk to us about the relationship between oral health and overall health, and how increasing access to dental care can impact individuals and our healthcare system? On top of this, what are some metrics that you believe would indicate the Canadian dental care plan is succeeding?
Yeah, thanks so much, Brandon. I think the first thing to realize is that there's nothing special about the mouth. And what I mean by that is that there's nothing special about the mouth that makes it not part of your body and not part of your health and not part of your overall health. And I remember in medical school learning about some of these associations that they've seen in the literature, things like poor oral health was correlated with cardiovascular disease, with diabetes, having a low birth weight infant, metabolic syndrome, strokes. And then as I started to work in the healthcare system, I started to find out deeper into the literature and find out that there's actually good data on causation, that poor oral health is a chronic inflammatory state that actually worsens diabetes, worsens things like aspiration pneumonia. When you provide oral health care, you see that people's diabetes improves, similar to adding another oral diabetic agent. You reduce the risk of aspiration pneumonia in long-term care settings. You reduce people's cardiovascular risk category. And not only are there the health benefits, kind of the physical health benefits, there's really important social and mental health benefits. People's self-esteem improves, their employability improves. Just think about how important it is in our society to have, a healthy smile, and how important that is in social interactions, in job interviews, and the way we carry ourselves day to day. And so I think this is a huge step forward to have this plan, because we're starting to recognize that oral health is an important and essential part of your overall health. In terms of what we can expect to see in terms of the impacts on individual health and impacts on the system, that's really going to come down to, the biggest question I have, which is, does this program actually improve access? Because that's what we care about. So we've created this program. It's a great step in the right direction. But we also know that just because you have insurance, as you mentioned, Brandon, doesn't mean you have access to providers. And when I think about some of the biggest challenges we have in our healthcare system, in our Medicare system right now, it's hard to open up a newspaper without hearing about our primary care crisis, our overcrowding and emergency department crisis, our surgical backlog crisis. We are funding this care, and probably the biggest issues and why we're getting such challenges in those areas of our healthcare system is actually less on the funding side and more on the coordination and delivery side. In primary care, we don't have a system where we've trained the right number of primary care providers and put them in the right places and created sort of a catchment area like you have with schools, where you say, okay, I live in this neighborhood, I have this primary care team taking care of me. Similarly, in emergency departments, which is where I work, I go in every shift into my downtown Toronto emergency department, and more than half the beds are full of admitted patients who are waiting to go upstairs. And so there are times that I'm operating a 2 or 3 bed emergency department in the busiest, densest part of the country. It makes no sense. And we need to look at the whole system and how we coordinate care, how we move alternate level or low acuity patients out of the hospital and create that space for people to move up from the emergency departments. Similarly, with the surgical backlog, you have family physicians who are calling each individual surgeon, trying to figure out, how do we get someone to the right surgical care instead of centralized referral lists and things, where we leverage our resources in the most efficient way possible. So we know that funding doesn't necessarily equal access, and for this dental care program, there's the added complexity of it being now this multi-payer program, where there's going to be this kind of public set of fees, and then we don't know how it's gonna interact with people's other insurances, how it's going to work in terms of the fees that dentists can set privately, and that difference, and how it's going to be made up or not made up, and there's all these complexities that I think the most essential piece is for us to say, are people actually getting the care that they need? Because ultimately that's the most important thing. We know there's huge inequities in our system right now. 4 in 10 low-income Canadians avoid seeing a dentist due to cost. It's less than 1 in 10 when it comes to physician services. So we know that having that coverage is very important, but it's not the only thing. So what I'm looking forward to is, I think both things can be true. This is a massive expansion of our investment in public dental care and a commitment to your oral health being part of your overall health. And I also have concerns that this won't necessarily lead to access increases for some of the most vulnerable individuals in our society. And I think it's really important that we collect that data and that we hold ourselves accountable to saying this program actually needs to serve those that they're intended to. And I think that speaks to Joan's point about some of the specific populations where that might be even a bigger challenge. We need to look at other delivery mechanisms and really ultimately take ownership of our system and say, whether it's dental care, whether it's Medicare, we have to actually make sure we're coordinating that care effectively to get the best outcomes.
Thank you for those insightful comments. I absolutely agree that dental care is healthcare, and we really need to make sure that the Canadian Dental Care Plan isn't just something that looks good on paper, but actually delivers real world results. If we want to truly see, for example, ER visits for dental pain significantly going down, people need to actually have access to a provider in a timely manner. And, time will tell how well that actually happens. I do think that we need to view this, as a stepping stone, as some of our panelists has mentioned, of, having this be a stepping stone towards fully integrating dental care into our universal healthcare system. And with this idea in mind, I would like to open up a discussion with our panelists. Basically, while this Canadian Dental Care Plan, it's undoubtedly a step in the right direction, what do each of you think our next goals as advocates for this issue should be in working towards making sure every Canadian has access to dental care? I know we've touched on some of them, but I'd just like to open the floor for people to discuss this some more.
Well, I'm the only one who is not on mute, so I'll start. And I would like to say that I absolutely agreed with everything that both Paul and Hasan have said. But I think one of the things that was a highlight that both mentioned was we need to ensure the success of this. And how will we do that? Well, at the moment, there's very, very little regulatory oversight in our oral health care system. The colleges of dentists across the country and other oral health providers, they all regulate for competency. There's no regulation through any government body with regard to oral health for actual success of delivery of care. And so it's just not available. We do have a federation of those colleges, but the issues they deal with have to do with, generally speaking, again, what do dentists need to know in order to be competent, in order to be graduated, in order to practice? Those kinds of issues. There are others, but they're mostly to do with the practice of dentistry and involving dentists, not so much anything to do with, really, access to care. And again, there is no coordination regulatorily between decisions that they might make as a group, as a federation, such as overall approval of dental anesthesiology as a specialty in this country, so that there are more anesthesiologists available to provide general anesthesia that is specific to oral dental care. But the provinces have no obligation to act on that approval. And since the date of their approval, which is over a year ago, to my knowledge, not a single province has bothered to. I think I don't know if you lost me here, but can you still see me? Yep. Here, I'll put on low power mode. It just told me that I'm low battery. Sorry. Anyway, I'm back. And so I would like to say that in terms of that kind of oversight, one of the recommendations that we made, and actually other academics have made, is that a body be put together that would have provincial and federal combined representation, and maybe representation for the public, but that would start looking at the success of this plan. How is it doing? What are the measures? I don't think this is the kind of public service that we should wait 5 years for a review. If, for one, it could have gone wildly off the tracks or show little benefit, in which case there's great opportunity and perhaps inclination for people who don't want to spend public money on it to close it down. So I think we should set up a body that would look at some of the most important aspects of administration of this, that would sort of be in agreement by both the provinces and the federal government, that could kind of set out almost contractually, but that would confer with every interested party, the doctors of the country, the dentists of the country, the hospital administrators, other clinicians, every specialist. We need to have oversight where everyone agrees that certain things are priorities, and that we can work towards agreed goals. I mentioned lack of trained providers, and I think more dentists need to be given privileges in hospitals and in other out of hospital settings, but so that they can receive these fees. But I think I've said my piece. Thank you.
Thank you, Joan. One thing I would like to add to your comments, where you mentioned that, moving forward, one of the things we need to consider is how politically stable this program is, because it could be something where, the future governments could look at cutting this program, whether that be, one fell swoop cut, or, the death by 1,000 cuts that we've seen with the existing public dental programs, where the fees the programs pay out get de-indexed from inflation, the income cutoffs get de-indexed from inflation, and fewer procedures are covered, making it so that, fewer dentists will actually see these patients. And one of the things that I think we really need to focus on when we're looking at the political stability of this program is the inherent weaknesses of targeted programs, because there's a sense of instability created when large segments of the population are paying into these programs through their taxes, but not actually receiving any benefits. It creates a sense of resentment where people see this as, you're getting free stuff and you should be grateful for what you have, rather than, you deserve this. This is something that everyone should have as a right. So seeing the Canadian Dental Care Plan as a stepping stone towards a universal system, I think is essential to create the political stability to make sure the plan lasts in the long term. And because when everyone buys into the system, there's much broader pushback, which makes it much harder to cut funding for these programs. And, that's why, with all the faults that we've seen with Medicare, it has stood the test of time much better than the public dental programs, whose, public dental spending around 1980 accounted for around 20% of overall dental spending. And now we're at 6%.
Yes. Yeah.
So I think that's something that's unacceptable, and we need to try to strategize to not have that happen again with the Canadian Dental Care Plan.
Just one comment on that. Sorry, Paul and Hasan, but is that the way that the provinces have treated fees in these targeted programs, where in BC, for example, fees for the public dental plan for persons with disability have not been increased effectively since 2004. They were just minorly changed to delete access to general anesthesia in 2007. And so the plan has remained identical ever since. I know that even still they pay better, I think, than the Ontario plan pays. Dentists, of course, are disinclined to accept patients like this if they're going to get, in BC, effectively the fees are 40%, close to 40% of the current fee guide. I do have other issues about only dentists deciding on fee guides. I do believe that universal indicates that we would have more negotiation, just like doctors do. But anyway, I will stop talking. Thank you.
Thank you, Joan. Hasan, would you like to chime in?
Yeah, thanks so much, Brandon. I certainly agree with your point about the difference between targeted and universal programs. I think with a universal program, you do get that kind of collective buy-in. I think people are far more invested in making sure that those programs work. Ultimately, though, whether it's universal or it's targeted program, the way we're going to make a program work and make sure it's efficient and effective is by measuring the outcomes, right? Is having clearly defined metrics of how we're going to define success, measuring those, and doing something with that information. And so, even with a targeted program, what we still need to know is who's accessing this care, what are their quality outcomes, who's not accessing those care, that care, and why. And so, we may find it's a geographic issue. We may find it's an age issue. We may find it's related to disabilities and other difficulties with access or language. And then, and I'm surprised I'm going to hear myself say this, but then we need these robust kind of pilot programs. And Canada's always talked about as this country where it's just pilot program after pilot program. But we have an opportunity here to actually create these pilot programs, test them, and scale them up, and actually scale them up with what works. We have some examples of this in the dental care space already of tremendously effective, cost-efficient, high-quality care outcome pilots in schools, providing using dental therapists to provide dental care for every child in a school. Things like that are going to help us on the delivery side of things while we're standing up this program to say, let's find a way to make sure we reach all of the most vulnerable members of our society and make sure they're not falling through the cracks. But the only way to do that is to do it in the right order and do it systematically and hold ourselves accountable and make it as transparent as possible that this is what people deserve. This is what is best for the individual, best for our society. And then we're going to make sure that that's the kind of North Star we're going to keep working towards.
If I may chime in, Brandon, thank you. Yeah, just to build on what Joan and Hasan have been saying, I agree 100%. I think clearly the data are really important. And to be fair to the government, they explicitly said and are spending money with Statistics Canada to gather data on what's happening with this program. Precisely what data, I'm not sure. But they have said they're spending money on that to gather the data. So like much else of this about this program, we've got some really good ideas and good intentions, I think, and we need to see the details to see how effective that would be. But we do also know that governments understandably really look at the economic impacts of all of these sorts of investments. So there needs to be good data on the costs and the cost savings that come from this in terms of how much it's costing to treat somebody in a dental office versus, as Hasan has been referring to and has been reported widely, the cost of people going to an emergency room. And with all respect to the physicians and the other health professionals there, being often prescribed antibiotics or being, trying to help, but not getting the definitive care that they would need, which may well be some form of surgical intervention with a dentist. So that's completely inefficient, and it's very well documented. And I'm not criticizing any of the health professionals in those ERs. It's just they don't have the facilities to be doing what's necessary, and that's an enormous waste of resources. Waste of money doing that, waste of time, etc. So that's an example, and there are countless other examples of the sorts of data we could be gathering to try to show the benefits. On top of the fact that we really need to have really good data on the needs of the population. We need to understand, because there are lots and lots of people in Canada who have very good oral health. Their needs are really absolutely minimal. Including a lot of people, I'm sure, who would be covered by this program. So we need to understand what the needs are, because there's also a smaller proportion of the population, but nevertheless significant part of the population, who have enormous needs, who have rarely seen a dentist, or have great difficulty accessing, as we talked before, people with disabilities, people living in long-term care centers, etc., people living in rural areas. So we really need to understand the needs of the population and better fit the services to those needs in a whole range of ways. Hasan mentioned a few examples. We talked about bringing the services to people. Brandon mentioned the fact that we need to change the compensation systems to recognize the difficult care and the different needs of different people. So I think we need to do that sort of thing. And of course, we need to integrate the care. You know, why does somebody who's got toothache, who needs, you know, they need that sorted out, why can't they get good urgent care in a community health setting, not a hospital setting, a community setting where there are nurse practitioners, there are social services, there are doctors, there are dentists, there are a whole range of people who in the evenings, over the weekends, they're there to serve people who've got urgent needs, a whole range of urgent needs. Why don't we have those services rather than always ending up going to the hospital? And again, that's, you know, it's we've all heard this record countless times, but I think that's really important to think about as well, integrating oral health professionals with community health and social services. And finally, I must say, you know, I'm a public health specialist. We're focusing, and as we should do, on delivering care, but we need to recognize that delivering care is a model which frankly doesn't work very well for any chronic diseases. We need to be focusing much more, as we say in the world of public health, upstream. In other words, we need to be preventing the problems before they occur. Now, of course, there will always be people who get ill and who have needs for care, and will always need doctors and dentists and nurses and everybody else, and hospitals. But if we were much better at working on our environment and our policies and our programs so that people were much less likely to get ill in the first place, whether it's dental decay or heart disease or diabetes or whatever it may be, then that's going to really reduce the burden on ERs and everybody else. So I really think we need to think about that, whether it in terms of dental diseases, whether it's fluoridating the water supplies, whether it's taxing sugary beverages, whether it's setting up, as was mentioned by Hasan, school programs of one sort or another. There's a whole range of things we could be doing, promoting the better availability of cheap, healthy foods, and making junk food much more expensive, or if you want more difficult more difficult choice, making the healthy choices the easy choices. Back to you, Brandon.
Thank you, Paul. And yeah, I think all of these comments build on one another. Originally, I had this kind of posed as a second question, but in the time's sake, I think I'll just kind of add this as a comment, in the sense that I think we've already touched on a lot of these answers here. But, you know, in the last few decades, dentistry in Canada has become increasingly commercialized, with dental clinics focusing more on luxury and cosmetic services. And I think, you know, the Canadian Dental Care Plan, as is, will basically try to give people without insurance a fighting chance at kind of muscling their way into getting some chair time here. But it's not going to fundamentally change the triaging system that we have. You know, it's still going to be dentists making decisions based on how they can make the most money per unit of chair time that they have. And fundamentally, we need to look at shifting away from viewing dental care in this way and looking at it as a primary health concern. And we can improve public health outcomes by distributing care in different ways and focusing on different things, as our other panelists have mentioned, with the alternative dental delivery models. And, you know, shifting away from that private practice fee-for-service model. I wonder if any of our panelists have anything to add to that before we move to the Q&A from the audience.
Well, I think really we need to find a way to get more response from dentists, because I'm not sure. I mean, the only dental association that's been really vocal in terms of putting out publications is the Ontario Dental Association. And in general, they have not really shown any obvious willingness to even accept this plan or recommend it to their members to accept it. So even the CDA, it's not clear that they have a sense that dentists will necessarily sign up. We have to figure out what does it take to make dentists believe that their first goal is to protect health and not to run a small business. It's true they have to do both at the moment. But then again, doctors do the same. I think we have to remember the history that when doctors were first presented with, as Brenda's book will point out, but when they were first presented with the concept of Medicare, doctors in Saskatchewan went on strike. They went on strike in my province as well. Doctors were not really in favor, and yet here you are now as an enormously successful organization speaking for the need for Medicare in our country. And it is, I think, the most valued public service in the country through surveys. That's what people say. And so I think we need to find a way to enhance dental buy-in so that it's not as commercialized, and hopefully it's not just about the money. There's something about the way we teach dentistry or integrate it into the rest of the public care healthcare system. I know many wonderful dentists who care, but the associations on the whole are nervous about buying in. So thanks.
Thank you, Joan. And I absolutely agree. I think the way I like to look at it is, the economics are kind of, I think it's the primary driver of these factors. Trying to increase the education for dentists on this while the economics are going in the other direction is kind of like swimming upstream. So having kind of that dual approach, I think, is absolutely necessary. I would like to open up the Q&A now from the audience, starting with a question from Carol Ann that says, how can we encourage and empower dentists to embrace this plan and open their clinics to individuals with disabilities? I'd like to open that up to our panelists.
I'm sorry, could you repeat it again, Brian, please? How can we encourage?
How can we encourage and empower dentists to embrace this plan and open their clinics to individuals with disabilities?
Well, I think you have, sorry.
No, you go ahead, Paul.
I think we have to recognize, as Joan mentioned earlier, that if we're focusing in this question on people with disabilities, that for a start, there's an enormous range of disabilities. And so some people can quite readily come to a routine dental office and with relatively minor adaptations of care can get very good quality care. And then there are others at the other end of the spectrum who really require quite a significant change in the infrastructure and the approach, et cetera, et cetera. So there needs to be a recognition that there's an enormous range of disabilities and the implications for dental care, just as the implications for their other healthcare and their other social services and other services they need. And it needs to be recognized. So it needs to be recognized from the patient's perspective, what they need. But it also needs to be recognized from the health professional's perspective, what they need and the time it takes to do this. And the fact that, classically, the private sector is not good at serving people, whether it's people with disabilities or whomever it may be, who are very different and who require more expensive, complex care. So this is where the public sector comes in, and this is where we have to think of funding in different ways, and again, bringing it into universal coverage, so that we can build the system infrastructure, the physical infrastructure. We can have the training for the professionals, and there's other health professionals around, so that sometimes it may be complex, so that the doctors and the dentists and nurses need to be working together to care for particular groups. So it's complicated, but there are plenty of people, I'm sure, and Joan knows lots more about this than I do, that who have disabilities that could be going to routine dental offices and being cared for properly there.
A huge proportion. Yeah, yeah, a lot. The one other thing I wanted to say was you're all conscious of the need for good diagnostic equipment and measures, and it's built into your medical systems now. It's a real challenge to deal with diagnostics for a lot of people with especially neurodivergence, and we have to sort of address that. But I wanted to make one other point, which is maybe heading some things off at the pass, that it would be wonderful if the doctors of Canada could also ensure that they have, I'd be interested to see what Paul has to say about this too, as well as Hasan, but if the doctors could have a bit more understanding of oral health. And I'm going to give a tiny story of, I advocated for an infant who was really struggling with repeated instances of pneumonia, kept being taken back to Children's Hospital, very challenged little guy. Anyway, after a period of time, he was so upset, but he kept on having this repetitive, they give him antibiotics, go away, come back again. And finally, when they contacted me, because he seemed to be so unhappy all the time, what should they do? He was crying and whining, that we suggested what was the dental situation like. None of the doctors had even considered it, and the parents hadn't either. The reason was the kid was on a feeding tube. And so many people assume that if you're not eating food, therefore you're not eating sugar, therefore you're not going to have dental problems. And I'm sure someone like Paul will tell you that's not the truth at all. And or Brandon probably too, that people need their saliva around their mouth. So when they examined him, he had 10 cavities and some teeth had to be pulled. But those were pediatricians, and they're very caring and knowledgeable people. They had not considered his mouth. And I think, you were making the point, Hasan, that, the mouth is part of the body. So it would be wonderful if you could also be advocating in your own field for that greater crisscross, that therefore earlier on, people are identified by their doctors as perhaps needing the services of dentists. And there might be greater integration if we're all kind of on the same page a bit.
Absolutely, Joan. And yeah, it brings up a lot of interesting points. And I feel like we need a very multifaceted approach to actually address these issues. Another question that I'm seeing from the chat, this is kind of posed in multiple different ways, so I would like to make sure that we get to this. But it basically says, will all dentists honor this coverage, or will they be permitted to drop out? I wonder if anyone wanted to start with this, or I could also discuss as well.
Why don't you go for it, Brandon? You're the practicing dentist here, so
Sounds
we're
good.
not.
Yeah, so dentists don't have to take people under the Canadian Dental Care Plan. The hope is that the conditions, the actual details of the fee guide, once they're released, are attractive enough to dentists where they'll be willing to actually accept these patients. And really, as I've mentioned, one of the biggest things we're going to look out for is how close the fees the Canadian Dental Care Plan will pay out will be comparable to private plans, because once there's that discrepancy, dentists will see it as, they can make more money treating people on a private plan rather than a public plan. One of the issues I think we're going to face as well is if there is a discrepancy between public and private plans, what mechanisms will be in place to make sure that these patients don't face out-of-pocket expenses through kind of the balance billing of that remaining fee. Because this is also, disciplining dentists does tend to fall in the provincial dental boards, but this is a federal dental plan. So how will those things actually be coordinated? How will, when the tires meet the pavement, how will that actually affect people? And I think the details of the plan will be a big factor in whether or not dentists are willing to uptake these patients.
So, like Brandon and even more so Paul, I'm sure, my organization has had some contact with the federal ministry and other individuals involved with the plan. So it's been intimated to us, at least, that it will be very similar. At least the plan for persons with disabilities will be very similar to the Canadian non-insured health benefits plan that currently covers persons who are Indigenous in Canada. That pays that fee guide. It was modernized in 2018-19, and it's fairly comprehensive. So it's a very good fee guide. I've been told that it will include coverage for dental anesthesiology, or dental anesthesia, I should say. But which is nice because, for example, our Pacific Blue Cross plan doesn't pay for persons with disabilities here in BC. It doesn't cover DA. So there's challenges when it doesn't. You've got more options when they do. The 85%, however, of the NIHB plan may not thrill dentists. And one issue will be whether the federal government says, if you take this plan, you may not balance bill. And there's I think certainly a possibility that that will be the case. I mean, if you're suggesting this is a plan for people who are they have to be low income, but there's in this country no greater social determinant of health that is more closely linked with poverty than disability. So they are likely to be both impoverished and disabled. And so then to ask them to come up with 15% of the cost is an odd thing. The intent is that this would be the coverage and dentists would accept it. But the fee guides go up every year and there's nothing restricting them. They have for the last decade, 12 years, gone up more than the cost of inflation. The last couple of years, they've gone up significantly more because of the impact that COVID and things had on dental practices. So we know that there could quickly be a mismatch between, the recommended fees that are set by dentists, by their dental associations, and the plan. So we'll have to see how that goes. And like Brandon says, there is no law that says a dentist has to accept the plan, offer it, treat people under the plan. And let's be honest, they weren't. I mean, that's why there was this anxiety to have public protection. They weren't receiving care. People who are low income, and so, which is the majority. I mean, people with disabilities is a smaller proportion of people who will have access. But if you're low income and you weren't, so the dentist may be able to just carry on as always. I think our greater hope is for dental hygiene, which is essential to meet the goal that Paul mentioned for preventive care. Let's stop it before it starts. If we could get dental hygiene into, children's centers, into other organizations, into schools again, wouldn't that be fabulous? But if we could have dental therapy again, it crashed, but it's restarting, and there's a new program in Saskatchewan. We could maybe provide greater access, even if the dentists are not willing to accept it. And please go ahead, either of you.
I totally agree with you, Joan. I think if dentists aren't willing to opt in and view dental care as a primary health service, we need to have alternative methods of getting that. And it looks at breaking dentists' monopoly on care, because when they're the only providers that can do things, it does give them so much leverage that they have they've gotten what they've wanted. The existing dental care system, where the public funding is such a small minor component, is what dentists have been advocating for a long time, where it's basically an irrelevant thing and the private system dominates. And that's why we're seeing many of the problems we have now. So finding the way to create that leverage, whether that be through increasing the use of dental hygienists, dental therapists. And I do love the model of a way of rapidly increasing dental therapy in Canada, is having the dual trained dental hygienist, dental therapist model. I think is a very successful model to look at. And it actually comes to one of the questions I see in there is in the Q&A for the audience is basically, if we don't have the data, for these alternative dental delivery models, how do we decide, which ones are going to be the most effective, the design of them? And I think looking at historical precedents, as Hasan mentioned, with the Saskatchewan dental plan, or even its equivalent in New Zealand, where the children's dental program have had dental therapists and these dual dental hygienists, dental therapists, working in schools for a century. So looking at other countries, how they've successfully reduced dental decay, and even countries like Japan. Basically, in a very simple terms, Japan has included dental care in their universal healthcare system. And when that first happened, they kept track of what's called the 80-20 initiative, where they want to keep track of how many people who are 80 or older have 20 or more of their own teeth still. So trying to measure how well people are keeping their teeth into old age, and trying to support programs that help people keep their teeth into old age. And what they found is when they first included dental care in their universal healthcare system, only 7% of people who are 80 or older had 20 or more of their own teeth. And now that number is over 50%. We're seeing rapid improvements in people's quality of life. And I think looking at some of those models in other countries would be, great ways for us to try to improve the oral health of Canadians. We need to start measuring these things here so that when we do make improvements, we actually can track that. Yeah.
Just to add to what you're saying, Brandon, if I may, I agree. There's plenty of examples from other countries which show us, whether in dental care or other forms of healthcare, there's lots of things we can learn from other forms of healthcare as well about how to address the particular needs of particular parts of the population. But that, we need to have a commitment from the professions. We need to have a commitment from our governments and our political leaders and our decision makers in health services that we're ready to invest in this project of bringing oral health care into general health care, bring the mouth back into the body, as Hasan said right at the beginning of his comments so eloquently.
So I want to go back to my early points so that it's clear how challenging that can be. The Canada Health Act is simply a contractual arrangement between the federal government and the provinces, and the delivery and even what is considered essential health, essential, necessary medical care falls to the provinces, and it's not always aligned. And so it's really essential that we get the provinces lined up, but it's very difficult to get them to come to the table all together. And some of them have said they're not keen to even be part of this. They'll do it themselves, thank you, or whatever. But we need to, I guess, you're all within your individual systems, encourage your systems in your provinces to do that, to take that step, and for the good of all the people of the not only the province but the country. We promised mobility under the Canada Health Act, and and we promised universality. So let's make this part of the universal coverage. Absolutely.
Thank you. I just wonder if any of our panelists have anything else they would like to add before I hand over the mic to Zarif to wrap up. Awesome. So I'll hand it over to you, Zarif.
Thank you so much, Brandon, and to all our panelists for a very engaging discussion. I'd like to give a shout out to everybody who attended today. The chat was so engaging. I don't think we've ever received this many questions for a Q&A. I think we're close to 30 questions, and we have not been able to go through all of them. So we will work on a follow-up and to try responding to those questions. But yeah, thank you so much. Canadian Doctors for Medicare is fully committed to improving the public healthcare system, fully committed to universality. So please consider making a donation today. It goes really far for us. If you're a practicing or retired physician or a medical student or a resident, we encourage you to become a member. And yeah, we'll definitely be in touch with all of you. Thank you so much again for joining us today. And there are a lot of struggles ahead in public healthcare, but we have power in numbers, and hopefully, a lot more good news on the way. Thanks so much, and take care.